Hello everyone, it's Adam Ferrier back again. In this presentation I'm going to talk about healthcare in Australia, how it's delivered. Before I begin, I'd like to acknowledge the Wurundjeri people of the Kulin Nations, the traditional custodians upon the land who the university is situated upon. In this presentation, it's in three parts. We're going to look at the learning objectives, the healthcare in Australia and the workforce. The learning objectives are basically to have an appreciation of the complexity of the Australian health system, an understanding of the governance of the Australian health workforce, and a solid basis for when you explore issues in relation to resources required for the maintenance, management and operation of a health system. First of all, let's look at healthcare in Australia, an overview. And what makes the Australian healthcare so different? It's often useful to compare and contrast with other systems in general, and we are generalising significantly here. But in the United States, as formerly in Australia and the United Kingdom, healthcare systems were predominantly privatised, and your healthcare ability to access healthcare was on your ability to pay for the services. So that raised the issue of affordability. The United Kingdom in the early part of the 20th century started to move towards nationalising their health system, which really wasn't fully achieved until the Attlee government after the Second World War. And that has a system that's egalitarian, that regardless of your ability to pay, you'll be able to access healthcare. Of course, the problem with this is that healthcare is a finite resource and issues of rationing come up, so prioritisation has to happen. In Australia, we had predominantly a privatised system until under the Hawke government. It had originally started under the Whitlam government, but this was repealed by the Fraser government in the 70s. When the Hawke government in the 80s restored a nationalised system to Australia. So we had a mixed system, because we already had a thriving private health system and strong private healthcare insurance networks which had to be retained. So like the United Kingdom, we have an egalitarian system where regardless of your ability to pay, if you need healthcare, you're able to access it. The features of the healthcare in Australia is that public hospitals, which were a legacy from the olden days, they were administered by the states and funded by the states. We also had a strong private hospital system due to the rise of the middle classes following the gold rush in the 19th century. Our doctors are mainly private practitioners. They may work for sessions in public hospitals for a fee for service or an hourly rate, but for the most part, specialists work for themselves. Our GP forms the gatekeeper role in the system. The medical profession is politically very, very strong. We have a very strong federal system. The Commonwealth controls most of the taxation, so it's able to create or exert great influence on the states, even though the Constitution doesn't specifically give the responsibility of health to the federal government. We have a national health insurance scheme called Medicare, but we also have the option to have private health insurance in addition to, but not replacing the national health insurance system. Primary care in Australia is predominantly delivered by general practitioners in general practices. What's not on this slide and should be is the role of pharmacists in providing community primary health care and advice. It's also able to access primary health service or primary health care in community health centres and through domiciliary nursing. Local government provides some services such as home and community care and maternal and child health organisations, and less frequently there are community organisations that will provide advice, primary healthcare partnerships which link all these disparate groups together, and there are also some other consumer and self-help organisations that provide some primary avenues for primary healthcare. Now, Australians generally have a very high trust and regard for their health services and their health providers. There's an implicit expectation that the services offered will be of high quality. Mishaps do occur, but when they do, the impetus is not for suing people, but rather to make sure that it doesn't happen to other people. As a consequence of having a universally funded health system, we have low levels of malpractice litigation, comparatively speaking, to countries like the United States. Another feature of our health system is the insistence on privacy, and this requires direct communication between the healthcare provider and the patient. And it's the patient who decides who else may know, and there are very strict laws in place to affect this. The challenge is that our laws do not often keep up with developments in technology. This is in comparison with some other cultures where if a person has a serious illness, they're not told, rather their family is. This is a particular problem that they have, or a feature in some health delivery in places like in China. If we consider how the health system is governed, in Australia we have 3 levels of government. And the focus of health provision differs between these levels of government. The problem is they can overlap, but often they're more likely to be complementary. And it can differ between jurisdictions, or policy can differ between jurisdictions in different states and the Commonwealth, which can lead to conflict at times. But let's just look at the levels of government and their principal responsibility. The federal government in this country has the predominant role in gathering tax and managing taxation, and this makes them very strong in terms of policy and funding. The examples of which are Medicare, the system of remunerating medical personnel, and also funding for public hospitals via Australian healthcare agreements with the states. The federal government also funds aged care and the pharmaceutical benefit system. Conversely, state government provides systems that provide individualised care or services, and a good example of this is the public hospital system. And there is also the local government, which also has a role in the provision of healthcare, and they tend to provide systems that provide generalised care or services, but not always. The most common one that springs to mind is sanitation, such as garbage collection. This is a particularly important contribution to healthcare, because if our garbage was to pile up, we'd have significant problems with health. But local government's also involved with vaccination programs and funding for child and maternal welfare services. Another way of looking at this is to look at the relative roles as funder, regulator and provider across the different levels of government. And if we look at a table with the levels of government and the roles as funder, regulator and provider, we would see that the federal government has a leading role in funding and regulating. They are less involved in terms of a provider. They tend to be purchasers of care. But state governments are dependent on revenues raised through indirect taxation and grants from the Commonwealth based on GST revenue, and they're able to regulate within circumscribed areas, even though constitutionally they have responsibility for health. But what tends to happen is, because of the power of the federal government, the federal government encourages consistency across the states. But the leading role of the state governments is in the service provision and coordination of service delivery in each of the different states. Local governments generates funds from rates on properties, and to a lesser extent grants from other services or other levels of government. And they will form bylaws and things like that, and they will provide service delivery attuned to local needs. But comparatively speaking, local government has a smaller role than the other levels of government. Now, in terms of funding for health services, all Australian residents and permanent residents and citizens are entitled to healthcare regardless of ability to pay through the public system. This is through Medicare, which is funded through a 1.5% additional levy on people's income tax, and also through revenue raised through general taxation by the federal government. They're entitled to benefits via the pharmaceutical benefits scheme, and hospital care is provided once again via state governments who remunerate hospitals based on activity-based funding. It is an accident of history that dental care is not covered in Australia. We do have a very strong private system. As I said again, most medical practitioners are not employees. They work for fee-for-service or as individual private business. Private hospitals are in addition to public hospitals, not an alternative. But private hospitals give a choice of health provider, a choice of either using a public or private hospital to people that choose to take out private health insurance. Private health insurance also funds rebates for ancillary health and for dental care. Now, a feature of our private health insurance in Australia is a thing called insurance community rating. This means for each product that's offered to purchase when you buy health insurance has a common price across the region, regardless of a person's health status. Our private health insurance companies cannot deny a person insurance if they wish to buy it, and they cannot disqualify people for pre-existing conditions. This is a significant difference compared to the United States, which has significant problems with people being disqualified from obtaining health insurance because of pre-existing conditions. There are other sources of healthcare funding. The Department of Veterans Affairs, which is a Commonwealth department and has a separate budget from the health budget, this will fund healthcare for current and former serving members of the armed forces, and it provides a range of other services to support people serving in the military or who have provided service during the wars. And this can include personnel such as merchant mariners from the Second World War. Another source of health care funding, if you're involved in an accident on a roadway in each state, your health care will be funded not through the Medicare system but by transport accident insurance. These are usually state-based, and so they've got a different name in every state. In Victoria, it's called the Transport Accident Commission. In Victoria, premiums are paid via the annual vehicle registration, so car owners actually fund this system rather than licensed people. So if you have a driver's license but don't own a car, you're not contributing to this fund. But it covers anyone that's injured on the road as a result of a road vehicle injury. The downside of this is if you're knocked over by a bicycle on a footpath, you're not covered. There's some anomalies in this. If you are injured at work, your healthcare will be funded by workplace insurance schemes. These have different names in each state. In Victoria, it's known as work cover. And in Victoria, the premiums are paid by the business owners, and they're based on a proportion of the payroll of the employers, the total payroll of the employers. So it's an employment on cost. So if we look at the sources of income, the predominant source of income is from the federal government via Medicare, via grants to state governments, who then remunerate the public hospitals using activity-based funding for acute care and increasingly for other forms of care. Public hospitals, if you have a workplace accident, you'll be treated in a public hospital, but the costs of that will be paid by workplace accident insurance schemes. Similarly, if you're injured on the roads, you'll be treated in a public hospital, but your care will be paid by transport accident insurance schemes. And if you're a veteran, you can be treated in either private or public hospitals as a veteran, and your care will be paid for by the Department of Veterans Affairs. The other source of healthcare fund is out of pocket, and these are personal payments, and they are exceedingly unpopular with Australians. One other form of funding is through donations, and quite surprisingly, Australians are very generous towards making donations. Public hospitals often have appeals each year, and the most famous one in Victoria would be the Royal Children's Hospital appeal, which happens every Good Friday, and it's raises many millions of dollars. Now, you might be saying, well, what does it cost to see a GP? And GPs are paid for a fee-for-service basis, and an example of this is item 23. This would be the most common charge that's made. This is for a professional attendance lasting up to less than 20 minutes. And the Medicare fee at the moment for this is about $37. The Medicare rebate for this is the full $37, but the AMA encourages its members to charge a lot more than this. My health provider or GP will charge about $75 for an item 23 visit. If you require a longer visit, the fees increase. So an item 36 is for an attendance of at least 20 minutes, between 20 and 40 minutes, and the fee would be $71 for that. If you need an even longer professional attendance of at least 40 minutes, the fees go up accordingly to $105. And the common thing that's asked is, what does it cost to see a specialist? Well, this really depends on which type of specialist you see. I included here an example, item 132, for a consultant physician other than a psychiatrist. And so the first time you would go to see them, the fee that they would charge, the Medicare schedule fee, is $263.90. The benefit that's paid is either 75% or 85%, so you will have to pay the difference there. And most physicians will charge double the Medicare fee, so you're actually up for quite a deal of out-of-pocket expenses here. And there are thousands of items. If you'd like to go and have a look at the search, the items are available publicly via the federal government's health site. The way that the federal government gets agreement through across the country is through the Council of Australian Governments, and they have a national health reform agreement of a number of points of the sustainability of funding for public hospitals, for the establishment of national bodies, to ensure that there's transparency of the operations of health providers, and to ensure that they give good performance, to attempt to ensure that there's local governments local people are involved in the boards of management of hospitals. They're also responsible for overseeing general practitioners and primary healthcare, even though these are independent providers. There are agreements in relation to aged care, national disability insurance, and formation of business rules. The aged care and national disability insurance have really been moved outside the health area into portfolios in their own right. And there is a national health agreement. I'm not going to go through this in detail. You can stop the presentation and have a read of this yourself. But these are the principles in which the National Healthcare Agreement is formulated. And just to close this presentation off, I'd want to talk briefly about the workforce. Australian health practitioners are regulated by a central agency called the Australian Health Practitioner Regulation Agency. This has been an initiative of the federal government over the last 10 years to amalgamate all the state-based registration authorities into a national body, so that you only have to register once. And formerly, if you were practicing in a number of states, you had to get registered in each state separately. Now, they have a number of categories of staff or board of registration, and this is the list of them: the Aboriginal and Torres Strait Islander health practice, Chinese medicine, chiropractors, dentists, medical personnel, medical radiation personnel, nursing and midwifery. Occupational therapy has been added more recently. Optometry, osteopathy, pharmacists, physiotherapists, podiatrists and psychologists. To practice any of these professions, you need to have done a course of recognised education before you'll be accepted for registration. In terms of medical practitioners in Australia, the most recent data that I can find, even in January 2018, relates back to 2015 through the Australian Institute of Health and Welfare. There is something like 102,000, nearly 103,000 medical practitioners who were registered in 2015. 2 in 5 are women. 1 in 4 were aged 55 or older, and they work, on average, far more than 40 hours a week. 95% of them work in a clinical role, and we are training about 3,200 students each year. There's a breakdown of the medical workforce there. If you'd like to have a look at this, you can stop the presentation and have a read through it. But the most important, and I think the keystone of our system, is the role, the well-defined role of the general medical practitioner. They are a gatekeeper to our system, and they really are the foundation of the health system. They're the person that you would go to if you have a health need, and if they can treat you themselves, they will, but they will, if they can't, they will help you identify the appropriate person or the appropriate specialist to see. So the GPs and medical specialists are generally not employees. They operate as independent business people. They'll rent office space or use others' facilities from wealthier, more established health professionals or practices. These things are tax deductible as a business expense by doing so, and they're responsible for their own insurance and leave arrangements. Nursing, on the other hand, is the most numerous workforce in Australia. There are more nurses than all the other health professionals combined. In 2015, we had over 300,000 nurses and midwives in Australia, but nearly half of them, 4 in 10, were aged 50 or older. So 9 out of 10 work in a clinical role, and of these 300,000 nurses, nearly 24,000 of these were involved in midwifery. It's perhaps timely to look at the evolution of the health professions, because prior to the 19th century, physicians and surgeons were separate professions in their own right. The physicians were involved in the administration of medicines and poultices and things like that, but the people that actually did operations were the people that had the sharpest instruments, and these were barbers, people that cut hair. This is one of the reasons why in Commonwealth countries, if you are a surgeon, you're referred to Mr. rather than Doctor. In the late in the 19th century and the early 20th century, the roles, the training of doctors moved into universities, and the two became combined with a foundation degree of a Bachelor of Medicine and Bachelor of Surgery as a foundation requirement. Since the early 20th century, we've seen a rise in specialisation because of the knowledge that's required, and from the early part of the 20th century, the development of radiology and diagnostics, and also pathology testing in its own right. Pharmacists, on the other hand, have been registered formally and regulated, particularly in Australia, since the mid-19th century. Their roots lay with apothecaries, and they're one of the oldest registered groups certainly in Victoria. But the complexity of pharmacy health provision has grown, so that there's diversification now, so the development of roles such as pharmacy technicians to assist the pharmacists. Nursing in the prior to the 19th century, there have always been people that have given care, but it was really the 19th century where nursing became formalised as first a vocation and then a profession. From nursing, and this has continued to the current day, and certainly with a range of specialisation, but out of nursing has sprung what would be termed a number of roles from allied health, such as physiotherapy, occupational health therapy, speech pathology, and other areas, who have developed their own bodies of knowledge, which are far distinct from nursing in these days. So where has this left us? Well, it really has left us with a fragmented services and what's often called a delivery of craft delivery, according to different health professions. We have the dominance of the medical model. The political power of the medical staff has been zealously guarded, and there's often turf wars between the different allied health professions about who is responsible for doing what. As a result of this, that nursing, because it's been, I shouldn't say because, but historically it's been treated as the poor relation, and they seem to nurses pick up the roles and the treatments that after 5 o'clock when all the allied health professionals go home. But even so, as a system, this is good economics, because a craft-based system does provide the opportunity to ensure that we're getting the right person to do the right job for the right price with the right training. Now, where to go for more health? Well, the Australian Institute for Health and Welfare is a superb source of information if you're looking for things. There are a number of useful sites in addition to the journals, and I'll list these up these are available on the LMS. Thank you very much for bearing with me through this lightning presentation. It's not meant to be comprehensive, but really just an overview. If you've got any questions or would like to discuss any aspects of this, please feel free to give me a call via the LMS. Look forward to hearing from you. Take care. Bye for now.